against pregnancy, and ideally PTMC has to be performed at 20 weeks of gestation. In this case, both the presentations were late, and mitral valve area 1.5 square millimeters, anything less than that can produce pulmonary edema after second trimester because of the volume overload. And in this case, both the cases had severe mitral stenosis with PH. Vaginal delivery can be considered in class 1 and 2 NYHA patients, and in these, both the patients had class 3 NYHA dyspnea and PH. Cesarean section to be considered in class 3 and 4 NYHA patients only if there is no availability of PTMC. So the teaching points are PTMC in pregnant women is to be performed only by well-experienced people because there is risk to the mother and fetus. And the aim is PTMC is not to achieve maximum dilatation, but to achieve a mitral valve area more than 1.5 square millimeters, which will facilitate the safe continuation of pregnancy without any dyspnea and risk of pulmonary edema, while avoiding acute severe mitral regurgitation due to overdilatation. You have to always undersize the balloon, and pregnant abdomen changes the anatomy and the lie of the heart, and septal puncture is usually, the site of puncture is usually lower. So you have to use other techniques like septal bounds and staining and multiple views to perform the puncture. Thank you.
Thank you so much. That was amazing. Please join us on the podium, and then we will open this session for discussion. And I have the first question is, nowadays with the target age, even without symptoms, in case they are of childbearing age?
You're talking after conception or?
For conception.
For conception, severe mitral stenosis and moderate and anything less than 1.5, you should advise them against pregnancy.
Would you treat them anyway and then allow them to have pregnancy if they have a good Wilkins score?
Okay. I mean, I think that should be an option.
What we usually do, we have quite large experience with pregnant patients. In my sense, we of course place the shield to protect the abdomen of the patients, but we don't use sealing. We use only flow.
Yeah, I mean, this was all done in fluoro.
Yeah.
FluoroSafe.
Okay. And then, of course, the most experienced person in the team will do the procedure in order to make it very short. So, and the third thing, as you mentioned, you don't have to go to have the best result you may expect. So what you need to do is to have an acceptable result, which would happen most of the time, because these are very good patients, by the way, young and favorable anatomy.
Since we covered both the back and the front, and anyway the amount of radiation that is exposed is very minimal, because the maximum radiation a pregnant lady can be exposed to is 5 millisievert, and that is 0.5 per month. So this procedure it hardly reached the limits. Septal staining is you just drag the Mullen sheath down and you just inject. It stains the septum. It doesn't cause any puncture or any harm. And you get, if you notice, like the final frames, it has totally cleared off. You are just injecting the contrast. You are not poking the needle.
Those are excellent presentations.
I'm Sarah Fairley. I'm an interventional and obstetric cardiologist in New Zealand, so this is like the highlight of the meeting for me. And sadly, in New Zealand we have increasing rates of rheumatic heart disease, and we have one of the highest rates of rheumatic heart disease per population, along with my peers on the panel. And most of the obstetric patients I see have rheumatic heart disease. And the thinking now is that moderate mitral stenosis, if you can counsel a patient pre-pregnancy, they should be advised to not have a pregnancy and have their valve dealt with. And should that be by PTMC, great, but often it means they may need a tissue valve or a mechanical valve. In New Zealand we tend to, if their valve's suitable for PTMC, we would do a PTMC, but often the Wilkins score is not favourable, so they need to have a mechanical valve, which has issues with anticoagulation, but we get around that. But severe, as you've said, severe mitral stenosis in the setting of pulmonary hypertension, which both your patients had severe pulmonary hypertension, that's WHO class 4, so the risk of the mum surviving to term is incredibly low, so you're probably going to have a dead mum and a dead baby, which is pretty tragic. The other thing is, once you deal with the valve, particularly in the late trimester, if it was done expert procedure and an expert institute for people that don't see this very much. Just even when the baby gets out, or it's not well, so the mum can still go down the girdler quite easily, even with moderate mitral stenosis. So it's fascinating talks. Thanks for presenting it.
Thank you.